Hi everybody, my beloveds. Today's topic is all about ovarian cysts, mastering ovarian cysts. Let's go. And to clarify questions that were misunderstood, confused, during the last previous exams. So, let's go. Benign ovarian cysts are common gynecologic findings often discovered incidentally. While usually harmless, understanding their diversity, potentially complications, and management strategies is crucial for providing optimal patient care. You will be asked about that. So the vast majority of ovarian cysts, especially in premenopausal women, are benign, that is non-cancerous. Many women will develop at least one ovarian cyst during their lifetime, often without ever even knowing it, as they frequently cause no symptoms and resolve absolutely spontaneously. So what is clinical issue of that, my beloveds? The high prevalence of benign asymptomatic cysts means that incidental findings on imaging, like ultrasound performed for just other reasons, for checkup, are very common. It's crucial to avoid over-investigation and absolute unnecessary anxiety for the patient. A thorough understanding of typical benign features on imaging helps in reassuring patients and guiding appropriate, often conservative management's watchful waiting. This knowledge, my beloveds, prevents a cascade of potentially invasive and costly interventions for a condition that is often self-limiting. Another moment. The most common types of ovarian cysts are so-called functional cysts, which include follicular cysts and corpus luteum cysts. So, my beloveds, word functional is a Greek word, means work. So functional is working, okay? So these are directly related to the normal menstrual cycle and the process of ovulation. A follicular cyst forms when a follicle, which houses the egg, of course, doesn't rupture to release the egg, and instead continues to grow. A corpus luteum cyst forms after ovulation if the corpus luteum, the follicle remnant, seals and fills with fluid. So why it's so important? Recognizing functional cysts is key because they usually resolve on their own within 1, 2, 3 menstrual cycles without any unnecessary intervention. Their presence indicates normal ovulatory activity, or an attempt of it. Oral contraceptive pills can prevent the formation of new functional cysts by suppressing ovulation, but they do not treat existing ones. Forgot about that. Understanding this distinction is vital for patient counseling and management. For example, a simple cyst in premenopausal women is highly likely to be functional and key and can often be just monitored or even without. About dermoid cysts, major cystic teratomas. So dermoid cysts, also known as a major cystic teratomas, are germ cell tumors that can contain a bizarre assortment of fully differentiated tissues such as hair, teeth, bone, you name it, fat, sebaceous material, and like this. So this is because they arise from totipotent germ cells that can develop into any type of body tissue. As we think about that, of course. Might be speculation. It's another question, not today's topic. So why it's so important? While benign dermoid cysts have a higher risk of ovarian torsion, means twisting of the ovary due to their often heterogeneous density and tendency to be pedunculated, that is on a stalk. So they can also rupture, though rarely, leading to chemical peritonitis from the irritating sebaceous contents. Very rarely, in about 1-2% of cases, usually in older women, they can undergo malignant transformation, typically into squamous cell carcinoma. Ultrasound often shows characteristic features. For example, Rokitansky nodule, fat fluid levels, hyperechoic areas. Surgical removal, that is cystectomy, is often recommended, especially if they are large, symptomatic, or growing. Now, endometriomas are cysts. Endometriomas are cysts formed from ectopic endometrial tissue that normally lines the just uterus within the ovary. So they are often called chocolate tissue, chocolate cysts. No, of course, quotes. Due to their content of old, dark brown hemolyzed blood and desquamated endometrial cells, which resembles melted chocolate. So no ad of Nestle. Clinical issue of that, endometriomas are a manifestation of endometriosis and are strongly associated with pelvic pain, dysmenorrhea, dyspareunia, chronic pelvic pain, and infertility. They typically do not resolve spontaneously and can grow over time. While benign, they can slightly increase the risk of certain ovarian cancers, for example, clear cell endometrioid, later in life, although this risk is small. Management depends on symptoms, size, desire for fertility, and can range from observation and pain management to surgical excision, which can improve pain and potentially fertility, but carries a risk of damaging ovarian reserve. We know that. Another point, serous and mucinous, up to you to pronounce, serous, not. And mucinous cystadenomas are benign epithelial tumors that can grow to be impressively large, sometimes portion of the abdominal cavity. Mucinous cystadenomas in particular can become enormous, containing many liters of thick gelatinous fluid. Yeah. So what is clinical importance of that? Their large size of cystadenomas can cause symptoms due to mass effect such as abdominal distension, pressure on adjacent organs, bladder, bowel, and pain. The main clinical challenge is differentiating these benign tumors, their borderline or malignant counterparts, that is, serious mucinous borderline tumors or cystadenocarcinomas. Ultrasound features patient age, more concerning in postmenopausal women, and tumors markers like cancer antigen CA125 help in risk stratification. Surgical removal is typically recommended, especially if they are large, as a symptomatic, or have suspicious features on imaging to confirm benignity and relieve symptoms, my beloveds. Next, even benign cysts aren't always harmless. They can lead to acute, painful complications. Ovarian torsion, so twisting the ovary and fallopian tube around the vascular pedicle, is a gynecological emergency that can cut off blood supply, potentially leading to ovarian necrosis if not promptly treated. So why it's so important? Clinical importance. Torsion. Patients with sudden onset, severe, often colicky, unilateral pelvic pain, frequently associated with nausea and vomiting. Cysts larger than 5 centimeters, especially dermoids and paraovarian cysts, are at a higher risk. So prompt diagnosis, often with Doppler ultrasound, show absent or reduced blood flow, and surgical distortion are crucial to save the ovary. Rupture can cause sudden sharp pain. If a simple cyst ruptures, the pain may be self-limiting. However, rupture of a dermoid can cause chemical peritonitis, and a rupture of an endometrioma can exacerbate pelvic inflammation. Hemorrhage, bleeding into cyst, hemorrhagic cyst, often a corpus luteum cyst, can cause acute pain. While usually self-limiting, significant hemorrhage can rarely lead to hemoperitoneum and hemodynamic instability requiring intervention. TVUS, for transvaginal ultrasound. TVUS, is the gold standard imaging modality for evaluating ovarian cysts. It allows detailed visualization of cyst characteristics, size, wall thickness, septations, papillary projections, internal echogenicity, simple versus complex, which are crucial for distinguishing benign from potentially malignant features. Clinical importance. Ultrasound findings guide management. A simple cyst, anechoic, thin-walled, no solid components or septations, in premenopausal women, is almost invariably benign. It's a benign. Complex features. 6 septations, solid components, vascularity on Doppler, raise suspicion for malignancy, especially in post-menopausal women. So standardized reporting systems like the International Ovarian Tumor Analysis, IOTA, simple rules, and NEX model help predict the risk of malignancy and guide decisions on follow-up versus surgical intervention or referral to a gynecologic oncologist. Actually about oncology. So cancer antigen CA125, once again about this, is a tumor marker often associated with ovarian cancer, but it's a notoriously non-specific. Okay? Many benign conditions can also elevate CA125 levels, including endometriosis, fibroids, PID, pelvic inflammatory disease, menstruations, pregnancy, and even non-gynecological conditions like, liver disease or pancreatitis. So what is clinical importance? In premenopausal women with an ovarian cyst, an elevated CA125 is more likely to be due to benign condition than malignancy. Highly likely. It's just benign condition. Its utility is much higher in postmenopausal women with adnexal mass, where it has better positive predictive value for ovarian cancer. It should never be used as a standalone screening tool for ovarian cancer in general population. It's best interpreted in conjunction with imaging findings and patient demographics, often as a part of risk assessment scores like ROMA, Risk of Malignancy Index, RMI, or ROMA, it's a risk of ovarian malignancy algorithm. Okay. Another point. So the likelihood of an ovarian cyst being malignant significantly increases after menopause, and I will be asked about that. This is because ovulation, the primary driver of functional cysts, ceases. So any new ovarian growth in postmenopausal women is more inherently suspicious. So why it's so important? The management approach to an ovarian cyst differs significantly based on menopausal status. Premenopausal. Simple cysts, less than 5 centimeters, generally require no follow-up. Cysts 7 centimeters can be followed annually. Larger or complex cysts warrant closer follow-up or consideration for surgery. Postmenopausal, any new simple cyst less than 5 centimeters, often less than 3 centimeters or even 1, depending on guidelines, with normal CA 125 can be monitored. However, complex cysts, larger simple cysts, or any cyst with an elevated CA 125 usually prompts referral to a gynecological oncologist and consideration for surgical removal, as the pretest probability of malignancy is unfortunately higher. So while polycystic ovary syndrome has polycystic in its name, the cysts are usually numerous, small, peripherally arranged antral follicles, typically less than 10 millimeters, that have arrested in development rather than true large ovarian real cysts. Why it's so important? My beloveds, it's crucial to differentiate the polyfollicular appearance of ovaries in a polycyst from distinct large benign ovarian cysts, like functional cysts or endometriomas, that can also occur in women with polycysts ovarian syndrome. The polycystic itself is a complex endocrine disorder characterized by oligoanovulation, hyperandrogenism, and the characteristic ovarian morphology. While these multiple small follicles are part of the syndrome, they do not typically require individual management or pose the same risks like torsion or rupture as larger singular cysts. However, women with polycystic ovary syndrome may still develop other types of benign ovarian cysts independently. That's why accurate diagnosis of polycystic ovary syndrome involves considering all Rotterdam criteria, not just ovarian appearance. Okay? That's it. That's all concerning ovarian cysts, benign ovarian cysts, not benign. Thanks for your attention. Don't forget to follow and subscribe Dr. Y YouTube channel as well as my private channel, Dr. Y, in Telegram. So it's private, my beloved. So if you want to find my private channel, I suppose more interesting than YouTube channel. Tastes differ. So if you want to join this channel, tap in searching mode in Telegram, Dr. Y, WHY, like question, Dr. WHY, without question mark. Dr. Y. You click start and choose your plan. God bless.